This conference will now be recorded.
Thank you. Thank you, Terry. So, okay, so I have the honor of being able to introduce to you Roberta Carlin. And Roberta has been the Executive Director of the American Association on Health and Disability since 2002, when the association first received funding from the CDC's National Center on Birth Defects and Developmental Disabilities to provide and provided technical assistance to 16 state-funded grantees. And now, under Ms. Carlin's leadership, the AAHD has significantly grown and has developed a reputation as a leader in the field of disability and public health. Prior to coming to AAHD, Ms. Carlin was the Associate Executive Director and Director of Government Affairs at the Spina Bifida Association of America. And certainly Ms. Carlin has been involved in the field of disability and public health for over 30 years, working in the areas of health promotion and wellness, reducing health disparities, policy analysis, disability research, community engagement, health policy, partner and stakeholder engagement, women's health, and knowledge translation and strategic dissemination. Ms. Carlin has a long-standing commitment to eliminating health disparities between people with disabilities, including efforts to reduce the incidence of secondary conditions, advocate for community inclusion, and advocate for full accessibility for children and adults with disabilities. Ms. Carlin has a MS, a Master's of Science in Rehabilitation Administration, and a Master's of Arts in Counseling and Guidance with a law degree. So she is very well educated, and she also is a breast cancer survivor and underwent chemo, radiation, and multiple surgeries, which makes this topic specifically very personal to her. Please join me in welcoming Roberta, and she will be presenting on, let me move this slide forward. Oh, sorry. So is that, there we go.
The title slide is, yeah, the title slide is missing. I'm sorry.
Oh, no. Okay, so I somehow missed our title slide. But I will,
I'll take it, yeah.
Yeah, I'm sorry. I may just have somehow made that mistake when I put in that ACRM thing. See what happens to me? But yes, let's get started with the title slide. Go right ahead, Roberta, if you don't mind just sharing your title with us. Thank you.
Certainly. Thank you, Heather. And yes, the title is Breast Health and Women with Disabilities. And good afternoon. Thank you for inviting me to present today. And thank you, Peg, for making the connection. I had a little intro, but Heather covered it. So let's just move on to the next slide. This webinar will cover the 5 areas highlighted here. I'll do just a brief overview of AAHD, talk a little about health disparities in breast health for women with disabilities, and talk about our the projects that AAHD has been involved in for the last 10 years. And then give a very quick overview of our project activities, our deliverables, and our findings, and then just talk about moving forward and next steps. Next slide.
Oh, and this is Heather again, just chiming in. If anyone has any questions during the webinar, please feel free to enter them in chat, and at the end we will have a discussion. But also mute your phones until then. Thank you so much. Now back on. There we go.
Okay, the next slide. I see some of the names in the webinar, and I know some of you, and some of you I don't. So just a very quick overview of AAHD. We're a cross-disability national organization dedicated to promoting health and wellness initiatives for people with disabilities. We accomplish our mission through research, education, public policy, and knowledge translation activities. Our true priorities are to reduce health disparities, advocate for community inclusion, advocate for full accessibility, And most importantly, we are always the ones at the table striving to integrate disability into the public health agenda. How often our constituency is forgotten. AHD is home to the Disability and Health Journal, which is indexed on Medline, and we're very proud of the journal. It comes out quarterly. When we started out back in 2008, we were concerned we wouldn't have enough submissions and articles, and now to meet the 80-page requirement by Elsevier, our publisher, and now for those of you that have seen the journal and those of you that not, it's probably doubled in size or close to it each issue. So we're very proud of the journal. It's primarily a scientific, scholarly, and multidisciplinary journal for reporting original contributions that advance knowledge in the field of disability and health. Next slide. Our members are diverse. People with disabilities, caretakers, disability researchers, public health professionals, disability organizations, policy analysts, and healthcare professionals. And if you go to our site at www.aahd.us, you will see a listing of all our different initiatives and how they're quite varied, primarily because our members are also somewhat diverse. Next slide. I think in talking about this topic, I think the one thing that we all need to remember that the biggest risk factor for getting breast cancer is being a woman. And there's not much that can be done about that. Lightning doesn't strike twice, right, was a theme of one of our funded projects. We found women with disabilities, are as likely to get breast cancer as the general population. And some women with disabilities have even more factors for getting breast cancer than women in general. Our philosophy at AHD is we try and identify where there's gaps in services and programs, and then we begin to look for funding to support these initiatives. And way back in mid-2005, we started hearing anecdotally, and it was certainly going on before that, that women with disabilities did not really see themselves at risk for breast cancer, which is where the lightning doesn't strike twice theme came from. And of course, as we know, that simply was not true. And what we learned was that that mindset led to lower rates of mammography screening and even clinical breast exams. Next slide. One study found people with CP were 3 times more likely to die of breast cancer than the general population. Next slide. We also learned that in our preliminary research was that African American women and Latina women with and without disabilities were at risk for breast cancer. African American women tended to be diagnosed at a younger age than white women, and the breast cancer mortality is nearly 40% higher in African American women than white women, and that African American and Hispanic Latino women more likely to be diagnosed with larger tumors in late-stage breast cancer, which of course often leads to a poor prognosis. The HHS Advisory Committee on Minority Health, eventually referring to this challenge that racial and ethnic minorities with disabilities encounter, coined the phrase, next slide. Thank you. Coined the phrase, the double burden. And I don't think I need to read it, but it's basically indicating that minorities with disabilities experience additional disparities in health, prejudice, discrimination, economic disparities, economic barriers, and face and have difficulties accessing care as a result of their disability. And that's where they coined the phrase a double burden. And this was in July 2011. Next slide. Also, healthypeople.gov in 2014 found that women with disabilities are, again, less likely to have had a mammogram or a clinical breast exam in the past 2 years, again, often leading to larger tumors and later stage breast cancer, which again impacts survival and treatment. So overall, women with disabilities do receive mammograms at lower rates than non-disabled women, and unfortunately, these rates have not changed much over time. Next slide. This slide shows the percentage of women who received a mammogram in the past 2 years, and women, and again, this is 2010 data. 61% of women with disabilities received a mammogram as opposed to compared to 75% of women without disabilities. So we really see that there's certainly a challenge here. Next slide, please. So, you begin to ask yourself, why do these disability-based health disparities exist? And we have found through our work that there's multiple reasons for these health disparities and health inequities, and some have been identified in the literature, such as the citations below. Lack of knowledge among women with disabilities about the importance of getting mammograms, and often this is really even more of the issue, the underutilization of mammography among people with disabilities, women with disabilities, because of finances, which really should be now because of the ACA, but still exists, environment, but more so lack of physician referral and lack of awareness on the part of the physician. Next slide. So when talking about disability-based health disparities and why is there a delay in mammography screening, some of these are fairly obvious. Environmental barriers, attitudinal barriers, which seem to be really prominent, particularly in the urban areas. Not as much of a challenge with some of the physical barriers that women in more rural communities encountered. Cultural barriers, communication barriers, fear of the procedure, fear of the radiation, the accessibility challenges, and this one was also key. A lot of confusion about the conflicting recommendations. The American Cancer Society has one set of recommendations on when women should begin screening. U.S. Preventive Health Service has another. Susan Komen has another, and it's confusing to everybody, and that's often plays into the whole piece about why I should or shouldn't get a mammogram, because depending which recommendation you hang your hat on, and it's really something that needs to be discussed between the woman and her provider, because everybody's situation is different. Next slide, please. So, realizing all these disparities existed, and we were finding minimal programs or initiatives that were really focusing on women with disabilities and breast health, we began searching for a funder to help us just begin to educate healthcare providers as well as women with disabilities. And back in 2007, we were fortunate to get a little bit of funding just for Montgomery County, Maryland, which is where AAHD is located. And we focused on providing TA to mammography facilities, and we started to perform mammography facility assessments. These weren't at the same level as the type of assessments that evolved through our various projects, but it was it was definitely a beginning. And then that project moved on. We were able to move into more cities or more counties in Maryland and more counties in Virginia, and that was in 2009, 2010. Next slide. And then it even expanded more so to include Washington, D.C., wards 7 and 8, which have a high incidence of breast cancer among African American women. And you'll see the other counties. And then in 2012, we were really honored that Komen decided to take our project accessibility national. And we started working with Komen affiliates and grantees around the country. We went out and did facility assessments. We created, we had the money to create a lot more documents and fact sheets and a resource center and online training modules. So that was really, for 2 years, that was quite an exciting project. And then, we skipped a year of funding, and then the last 3 years, we were focusing on wards 2, 5, 7, and 8. Komen did a community needs assessment and determined they identified target areas in the DC area that they would be funding. And we were fortunate to get these grants, and we did a lot more educational workshops with women. We did coaching sessions, and we continued to do facility assessments of FDA approved mammography facilities. A little more challenging getting into facilities in 2018 and 19 than it was in 2007. Somehow we were seen as the ADA police, which we really tried to work around that and present this as a win-win situation. But maybe it was the way healthcare is practiced now, the concerns about litigation. We weren't really exactly sure, but so that proved to be, a bit more challenging for us. Next slide. So what did we do under these contracts? The 6 of them over the last 9 or 10 years. As I mentioned, we developed facility assessment tool to assess mammography facilities, which could also be used for healthcare facilities. We conducted these on-site assessments and then provided a report. We provided technical assistance. We hosted small educational workshops for women with disabilities and community organizations. We developed these online training modules and this resource portal, and we implemented, in the last year is when we implemented the one-on-one coaching session for women with disabilities, and really started to emphasize even more so the importance of self-advocacy, which we had emphasized throughout all our projects, but during the coaching sessions, we really have the opportunity to really highlight that more. Next slide. Oh, wait, I think back one more slide. Yes, thank you. We developed a podcast, which is on our website, on self-advocacy and women with disabilities. We had, the typo there on develop, but we have lots of fact sheets, tip cards, client reminders, posters, and all of this information. This is all on the AAHD website, and it can all be downloaded and used in various venues. Our primary partners on these Komen grants was the Association of Public Health Nurses that worked with us over the last 3 years for our DC projects, and the University of New Mexico School of Medicine. They did our program evaluation and helped develop survey instruments for the evaluation. So they were with us really from the beginning. And then, of course, Komen and the grantees were also partners. Next slide. And I'll just go through these very quickly. These are just some examples of some of the products that were developed. The assessment guide for mammography facilities, I believe, is about 30 pages, maybe a little less, 25 pages, but it's very user-friendly. And it's available online, and we also have them in our office if anybody's interested. Next slide. as part of the accessibility, we looked at parking lots, the building itself, the elevator accessibility, ramps, waiting room, the mammography suite, of course, the mammography equipment, the bathroom, sinks, accessibility. I mean, we really provided a comprehensive assessment because it was really important for staff to understand that you have any barriers are going to present a problem when serving women with disabilities or chronic, health conditions. Next slide. We developed. I'm sorry. That's just an example of what one of the pages looked like. It's an assessment guide for mammography facilities. I know it's not accessible, the size of the font on the site, but in the booklet it is. Next slide. These were the, this turned out to be a really useful product that we developed. We had this laminated, and this was something that could be kept at the nurse's station, at the reception desk, wherever the point of entry was, or when women were calling to make phone calls and arrangements for their appointments. So it really breaks down type of disability and just some important things to think about in order to serve women with different types of disabilities as they come for their mammograms. Okay, next slide. These were the online training modules. These were all on the website for the Project Accessibility USA. They are no longer on the website, but we're talking with our colleagues at University of New Mexico to try to get them updated and back up on the website. But this was very useful when we were working with different mammography facilities. They were short and they were very user-friendly and very well received. Okay, next slide. So what did we find? Of course, that women with disabilities often believe their mammography facilities are not accessible or welcoming to them. A huge disincentive, went once, never would go back. Fear of increased radiation exposure will give you cancer, a myth, but there were a lot of myths that really need to be accompanied by education. And many women felt that the mammogram itself would be painful because of the lack of training of technologists, and oftentimes it was painful. I mean, it's not a pleasant experience anyway for those of us that have had mammograms, and oftentimes with the technicians being poorly trained and not being skilled in positioning, it was, again, it was a barrier and a disincentive. The next slide, I won't read them all, but these are some of the testimonials, just really, the ones we heard more often from women through our, these various Komen projects. Again, technologists are not poorly trained, the radiation piece, not understanding that mammogram changes don't necessarily mean that you do have breast cancer, and then of course the issue with ongoing issue with accessibility. Next slide. These are potential mammography issues, again, and maybe ways to kind of help solve some of the challenges that women encounter and what they should do from a self-advocacy role. May need more than one technician to help them access a mammography machine. May not be able to stand for the amount of time required to complete the mammogram, and may not understand, what is happening to them, or may fear the test can be painful or very uncomfortable. So these are things that we would work with the technicians and try and make them understand from the point of view of the woman. These are things you really do need to pay more attention to. So that's pretty much these were our Komen projects. Next slide. So as we continued on these projects, we wanted to learn a little bit more and get more data, not part of the Komen projects, about what more information about the accessibility challenges that women face, and a little more quantitative data. So we partnered with FAMU, Florida Agricultural and Mechanical University, and we performed a small descriptive study of 80. These were self-identified women with disabilities over 40. The study did have IRB approval, and we did most of the recruiting electronically through email lists, Twitter, Facebook, specific Facebook groups. And then the data was collected using SurveyMonkey. And Barbara, my colleague, Barbara Kornblau is my colleague, and she worked on a number of the Chrome projects with us. I believe she was going to be calling in, and she could talk a little bit more about this when we get into the Q&A. But our results and what we found in regards to barriers were actually very interesting. Next slide. 37% of the women reported lack of physical access was a barrier. Over 32 reported other reasons such as parking and staff attitudes. Issues with transportation and parking over 10.5%. Next slide. 30% of the women said the mammogram was uncomfortable because of their disability. 12% reported lack of accommodations. 21% reported no accessible machine for their use. And again, we saw that more in rural than in urban communities, especially those that are part of these large conglomerates of hospitals that have all merged together and associated with universities. And 3% reported staff was unable to accommodate their needs. Next slide. And 32% had not had a mammogram in the last 2 years, which follows what we saw at the beginning of this presentation, that women with disabilities tend to not have screening as often as women with disabilities, some because they didn't know they needed a mammogram, other because of access issues. Again, access just keeps, rearing its ugly head throughout all of this. But yet the top reason for not getting a mammogram was the lack of an accessible machine, which again, we didn't find that urban, but this survey was done, this was done online, social media, so we had a real cross-section of women from all over the country. Next slide. The overall conclusions are that women with disabilities continue to face numerous barriers to mammography and breast cancer screening, despite legal and policy changes resulting from the ADA. Self-advocacy is a powerful tool that women with disabilities can use to advocate, to eliminate barriers and to their breast health needs. And I think self-advocacy is a huge piece that needs a whole lot more attention. Next slide. Just coming to the end here. What can be done to change practice and policy? Raise awareness of healthcare providers on the importance of accessible breast health screenings. Educate women about the importance of self-advocacy, and promote awareness of the need for accessible mammography facilities. And it is under the law, under the ADA, but we all know that compliance is often a challenge. And educate and encourage providers to adhere to federal guidelines in the procurement of diagnostic equipment as stated in the standards for accessible medical diagnostic equipment. And this is something Barbara can talk a little bit more about, but there are, the VA adopted accessible standards for medical diagnostic equipment under Section 510 of the Rehab Act. Implementation is not mandatory. So Barbara's a little more knowledgeable on that than I am, and she'll briefly talk about that. And next slide. These are just, this is something AAHD would love to start. I think Peg was involved in conversations way back, the National Breast Health Coalition for Women with Disabilities. We were all excited. We had a small group of women that really wanted to launch this, but as usual, if there's no funding and with all the deliverables that we have in AAHD, we couldn't really put the time and energy into launching this. So I throw that out there. If this is, something that this group would like to be involved in, we'd really like to prioritize, set an agenda, and get this on the map. And then I just bring up the other group, the Georgetown Breast Cancer Advocates, which is a model program throughout the country. And it's made up of breast cancer advocates and survivors who work together with researchers, clinicians, and other stakeholders to ensure that research is patient-centered, innovative, and evidence-based and accessible. And I'm a part of that group, and it's a dynamic group of women, and we work closely with the researchers applying for funds at Georgetown. And my role is representing the concern about that women with disabilities have. So when the applications are being written to Department of Defense or NIH or Komen or whomever, I try to encourage them to think about the accessibility issues just in terms of the trials and the studies. And I think that's it. Just one more slide, just the resources. On the next slide is just our website, and then the initiatives piece on our website will take you to the numerous products and fact sheets and tip cards that have been developed over the years. And the last slide is just my contact information, and a thank you to all of you, and thank you again for inviting me this afternoon, just to give you an overview. We have a lot more quantitative data on the Komen project, but I just couldn't get that into the 20 minutes here. Would be happy to go do that again if there's interest, but overall, we had very positive results, and we did see an increase in knowledge, attitude, and behavior change on behalf of the women and also on behalf of the healthcare providers. But we have more data that's, certainly broken down. And Barbara, I don't know if you're on.
I am on.
She's on. Okay, she's
Yeah.
on the phone. I hope you all can hear her. I don't know if
Yes. Hi, Barbara. Heather Taylor. Thank you so much for joining us. And also see a question coming in. But first I didn't think, Barbara, did you want to add something before questions, or do you want to?
The only thing I wanted to add is that one of the things that we found when we went out to visit the mammography facilities, it seemed that they were very willing to be accessible, and many of them thought, like I called one and they said, well, we're brand new. Everything we have is accessible, so you don't need to come out and see us. And when I went to see them, from the parking lot into the building, the garbage company had put a dumpster in between the two curb cuts. And when I went inside, they had a beautiful waiting room that was just a room, a big room. Yeah, you could do a 360 in a wheelchair, but you couldn't get out of your wheelchair to go to a desk chair because it was dangerous. There was no grab bar. They didn't really have an understanding of what the needs were. Yeah, it was a big room. They thought a big room for the changing area was going to be accessible. So, they had the right intentions, but they just didn't have the right information to make it accessible. Just wanted to add that.
No, thank you. And I think oftentimes, that kind of reflects what we found, going out to numerous sites over the years. Oftentimes they were like, well, yeah, you're welcome to come out, but we're totally accessible. And accessibility defined to them was perhaps, having signs on the door of the bathroom that it's accessible. Yeah, but it wasn't, because you couldn't get the door open. Or, having Braille in the elevators, which is all good. But, we define accessibility in much broader, and the attitudes of the staff to having materials available and accessible in alternative formats, um, the cultural concerns. It's much broader, and oftentimes when we actually got out there, they felt actually quite bad, because they really thought they were working with women in the community and really trying to reach out and serve them, and yet didn't understand that it's so much bigger than just being able to get in the door. And although that is certainly important, but the training of the staff, the allowing more than the 15-minute appointment, perhaps schedule 30 minutes, telling women that, feel free to bring somebody with you. So, it was interesting.
Yeah. Okay, I'm looking at Peg's question. Have you ever looked at the completeness of the exam? I've always been received reports that they could only examine 10% of my breast tissue. I figured it wasn't worth the pain, so I never went back. What I found, and again, I was doing, I was doing the assessments in Washington D.C. Metro, so it was an urban area. So all the places had mammography machines that went up and down. So if you were in a wheelchair, they could do a complete breast exam on you, because they could move you or move the machine. And when I say move you, if you need to be at a different angle, for example, that you can move your chair to a different angle. So I don't think in the circumstances of an urban area that was an issue. But I think that in some other areas, other parts of the country, as Roberta mentioned, where the machines are not as new and maybe not as adjustable, that might be an issue. So I would assume that is an issue in places where the machine is 10 years old or whatever, as opposed to what we were seeing here.
Thank you for, if anyone else has any response to that, feel free to jump in, or to add a note in the chat box. We can include your.
Sure, there's another question. Well, Peg said scoliosis complicates getting good images, and I could imagine that does positioning. But I'll tell you, I was really surprised when I have had mammograms, but I never realized the newer machines, they tilt in all kinds of directions. So, they can really get to breast tissue in an unusual way. Where you go on a plate, and I usually think of, okay, you go up straight to the flat plate, and you put the breast goes on the plate. But what I saw was the plate like not being flat and changing to different angles, like instead of being flat, going to like a 45-degree angle, and being able to do all kinds of things. So but I'm not a technician, so I don't know what they were doing. I just know what I saw. The other question from Heather is, accessibility has been a constraint struggle. Do you have recommendations on how we can empower and educate women to become advocates? We have a lot of information on the AAHD website, and I think that women can, you can download some of that and suggest that women bring that to the mammography facilities. One of the things that I did notice is when I gave people suggestions, like there was one place, another facility that was relatively new, and they were, please tell us what you think. What do we need to do? And they had a beautiful waiting room. This one was completely accessible. There was a bench. There was a place to hang your clothing. It was just missing a grab bar. And when I told them that, they said, oh, we didn't think of that. We're going to put that in right away. So I think that if you tell women to tell them what they need to do, and to give out some of our handouts from AAHD and say, here's what you can do to become a better, participant, a better neighbor, a better provider of healthcare for everybody. Here's what you can do, and here are the materials. I think that can really help a lot. And just, let women know you don't have to accept this. You can say, hey, you need to put a grab bar in there, or hey, here's some information on how you can make women with disabilities feel more welcome in your facility and provide them with better services.
Yeah, and I might add the podcast on self-advocacy, which is on the website, is great. A lot of good recommendations and good ideas and how to be an advocate in a non-threatening way, but be assertive. And we've gotten a lot of good feedback on that as well. Barbara did that with another woman who worked also on the Komen projects for the last couple of years. So, and both of them were actually out in the field. So I would certainly recommend listening to the podcast. We'd like to do a part 2, but
Absolutely. This is Heather, Roberta, and Barbara. I think, I always hear again and again, we don't know what we don't know. And I mean that in terms of service care providers. So empowering women to be able to speak up and educate them and feel like it's their right to say these things, and request or demand these things that they hadn't maybe fully considered, didn't realize, because we hear this over and over, and it really needs to change.
Well, Peg's asking, how can we revive the Breast Health Coalition? And what about a campaign to promote all of our excellent materials? Would Komen fund that?
Well, I don't have the answer about Komen funding it. We did not apply for Komen funding in this last cycle because they are moving away. Unfortunately, in my mind, and I'm sure Barbara would agree, they're moving away from outreach, education, and awareness in terms of funding their grantees in the DC region, and moving more towards mammography, actual services, and counting. If we could count how many mammograms women received as a result of our activities, perhaps we would have more of a chance. But I actually reviewed grants for Komen, and their focus is a little bit different. Not to say we can't revisit that with them, and I think we have talked about doing that. So that's not really a great answer, but I think at this point their priorities are not in, as I said, in outreach, education, awareness, but that certainly could change. And yes, I think it would be wonderful if we could resurrect this coalition. We actually got a URL, we put it on the website with a coming soon, because we just couldn't get to the next step. But I'd love to be able to do it. I mean, it's so important, and there's nobody really out there doing much in this area, and we need to work collectively. And of course, many of us lost a very strong advocate, Marilyn Saviola, this past year, and she was always, a champion in trying to get this coalition started. And so, yeah, I think, Peg, we definitely need to, because nobody's really paying attention to it. I mean, there's a lot of recognition. Yes, there are challenges, but we need to really mobilize collectively and engage women with disabilities. We need to engage providers, advocates.
Roberta, maybe we could maybe we could collaborate with United Spinal and do a webinar and promote the materials and stuff. Something we can look at.
Yeah, I'm sure they've always been very receptive. Absolutely.
Yeah. Okay, there's a question about, can you talk a little more about your recruitment efforts for the various studies? What did you find worked best for connecting with women with disabilities? I do all of my recruitment for my research online and through social media. So we connected with several groups on Facebook. I'm connected with chronic pain groups. I'm connected with various spinal cord injury groups, just general There's a good group called Disability Power for Community Integration. That's a cross disability group, and we just we ask people to take our surveys online, and that we've been pretty successful in being able to recruit that way. Okay, so what else? I guess the other question was about the coalition. So you mentioned that we have the website.
Yeah, we have the
and-
website. We just don't have, we need to put a steering group together and a steering committee and really, you know, sit down and identify really what are the priorities. Because as we've learned, you know, we can't be all over the place. We need to really stay focused. So I think it's important that we just put our heads together. And certainly conference calls don't cost anything. So we can certainly, AAHD would be more than pleased to take the lead on that and get a group of people together.
Sounds like a plan.
Yeah, and if that comes out of this presentation, if that's an outcome, I think I would be thrilled, as I know Barbara would, and I know Peg has always been a big supporter, and I'm hopeful that the others on the call see this as an important public health issue.
This is Heather Taylor again, and Peg and I both. I'm sure, Peg, I'm speaking for you here, that we can see what we can do to help promote it through the Women's Health Task Force as much as possible as well, at least sharing the information and reaching out to others who have passion in this area and really want to take this forward. I think we connect everyone together is one thing we could do.
That would be great. I'm sure that would be great. Well, we can certainly follow up after this webinar.
Okay, we have a question. Did you follow up with the mammography centers to find out how they responded to the accessibility audits? If so, would you please describe the results? We didn't do a formal follow-up with them. We did, you know, when I left, when I finished the audit, I went over it with them, even though I hadn't written it up yet, but I went over it with them and explained to them the kinds of suggestions I had. They asked questions and were very, you know, the one, especially when I said you need a grab bar, they were just so pleased and excited to have somebody give them this information on how it could be better. And the one that said you don't need to come because we're perfect, they were, you know, they were happy to hear it. They were surprised that they weren't as perfect as they thought they were. Although since they were new, they did have the best machine because it did, you know, moved in wonderful directions to give the most access. But they, you know, they were kind of a little shocked, but we're going to take a look and, you know, step back and look and see the suggestions and make some changes. So the reactions were pretty good. Now I do have to admit that there were some places that didn't let us in to do the audits.
I mentioned that before. I don't know if you were on the call at that point. Yeah, a change from 2007 when we were welcomed, and 10 years later, we weren't.
And ironically, we weren't, well, in one place, we weren't welcomed by the high up people, and the lower people who were in the clinic basically were very upset because they wanted us to be there. They wanted us to come. So it was very interesting.
That is very interesting.
Yeah.
How many people? Oh, sorry. Go ahead. I'm sorry.
No, I was just going to say, Peg says that let's commit to moving our work forward. You were saying how many? Sorry.
Oh, roughly. You said it's a surprise, and we think we're improving, and yet now you have some that are not wanting you to come in and point out perhaps their errors. But roughly what percentage do you think was really not welcoming this time?
It was just one, and I don't want to tell you who it was, but it's a large national organization that's been sued before. And
that's fine.
I think that, and probably you could all guess what it is.
And it's an HMO.
I think they could guess without that hint.
Yeah, but we didn't say, yeah.
Yeah, and they wouldn't let us in. And I was kind of surprised because I thought Doretta's been working with them really closely and stuff, and that they wouldn't, you know, they wouldn't be threatened by us. But who knows? We had trouble getting to the right person, and maybe I shouldn't have gone to the person I did because he was too high up, but I couldn't get to anybody, so that was the only way I could get there. Question, were you able to get much minority participation using your online recruitment strategy? Any suggestions for getting diverse representation in a primarily online survey study? We also did some live surveys and under a different, different methodology, and those we were able to get minority participation. As far as minority participation in other studies, I said I do all my recruiting online, and it just depends what you're recruiting and where you're recruiting. So I've had students who picked a topic that was very easy to get diverse populations, and some not so much. But if you, like for example, if you're recruiting on Twitter and you recruit through a group that is a member of or represents an underserved population, then you can, you'll get minority participation. It depends what you're doing. So it depends on the, so for example, if you want to get people from Hispanic community, if you follow Unidos on Twitter and you tweet to their followers, you may get more people from the Hispanic communities. So you have to be a little creative in what you're looking for and how you do it.
Yeah, and this doesn't address recruitment of minorities via social media, but our last 3 projects were focused in DC in wards 2, 5, 7, and 8, and that was
those communities are communities of color.
Yes, yeah. Which is a priority of Komen now. I believe it's called the BOLD Initiative. I'm not exactly sure what the initiative is, but they are really reaching out to women of color, and they're also reaching out to women with metastatic breast cancer. That's a priority for them as well.
Thank you so much. Do we have any other questions from our audience? Thank you both so much for being here today and presenting. And if anyone thinks of a question later, please feel free to reach out to myself and I can forward along the information, or you can reach out to Ms. Carlin directly. And of course, please let your friends know that we are recording this session and it will be up on the ACRM website.
And YouTube.
And, yes, thank you. Thank you.
So I just found that the other day. That's why I'm saying that.
Thank you. Yeah.
I just found their channel.
So, absolutely. So thank you so much for that. And if we don't have any other questions, I just want to thank you both for coming today, sharing this information, and really moving your mission forward. And I agree with Peg. We are happy to try and do what we can to help move and support your efforts moving forward in ways that we can.
Thank you. Thank you so much. We really appreciate it.
Yeah, thank you for the opportunity.
Thank you.
All right, take care, everybody.
Thank you.
Please contact me with any questions.
Thank you.
Okay, bye-bye.
Bye-bye.
Bye.